Good afternoon, everyone. Limbal stem cell deficiency is a very large topic, so I'll try to make it very simple. First, we must understand what is limbal cells. These are niche of cells which are palisade of Vogue, which is very close to the limbus, about a millimeter there, and it is supported by the mesenchymal cells like melanocytes, keratinocytes, the Langerhans cells, and then they differentiate into various type of cells, which are called the post-mitotic cells, the amplifying cells, and then the differentiated epithelial cells. Now, if you see these limbal cells, they are very closely associated with these mesenchymal cells, which actually helps in progression and multiplication of these cells. Now, if you have two controls, one without the exozymes which are coming out of the mesenchymal cells, and you de-epithelize the cornea, you will see the cells which have these exozymes in them, they tend to proliferate further much faster compared to the cells which don't have these exozymes. Now, if you have to salvage these limbal cells, you must know the anatomy where to get them. So here you can see that you are trying to dissect. First, you remove the conjunctiva, and then you mark these pigmented part of the conjunctiva close to the limbus, and you separate the Tenon's capsule from these conjunctival epithelium. Once you expose the pigmented part of the conjunctiva, you dig in about 100 to 150 microns into the cornea and then dissect out the limbal stem cells. So this gives you the correct idea where you can get the maximum number of stem cells, and then you cut them into small segments, and then you can use it for a simple slit procedure. You can also salvage these limbal cells into the amniotic membrane and then proliferate it in your lab. You need to have an amniotic membrane where you remove the epithelium from the amniotic membrane and then help these limbal cells to grow under a condition and allow them to then reapply them onto the cornea. And this is called a cultivated limbal epithelial cell transplant when you have a very tiny amount of limbal cells available in your place. Now, these are the extreme forms of limbal cell deficiency where you can see symblepharon and a vascularized cornea or a corneal opacity following a Now, if you see limbal cells, you will see these pigmented and non-pigmented epithelium. Now, both these conditions, they actually have limbal cells. So sometimes it gets very difficult to identify the limbal cells if you have a very hypopigmented eye. Now, these are the various conditions wherein you have extreme form of limbal cell deficiency. For example, if you have a chemical burn or you have Jogren's disease, a patient we have a Stevens-Johnson syndrome, or for example, a chronic allergic patients with Horner-Thanthus spots. These are the very extreme conditions of limbal cell deficiency. So how do you identify a limbal cell problem? So if you do a simple fluorescein staining, you will see a stippled stain of limbal cells, or if you do a optical coherence tomogram, you will see a very highly reflectile epithelium, which indicates there's a limbal cell deficiency. The other way is you can take a biopsy. You can do a simple blot biopsy, and you can stain them with PAS stain. You will see if there are goblet cells on the epithelium, you know these are conjunctival epithelium and there is a loss of limbal cells. One of the other ways is to do a OCT octa, and you can look for the typical presence of a normal limbal epithelial cells, and there will be a hairpin looped limbal blood vessels which is present in a normal limbal cell. And when there is an absence of limbal cells, these hairpin bands, they disorganize. So you can see the picture A and picture B. If you compare that, in one you can see a normal limbal cells, and the other one you can see that the hairpin angular vessels are missing. Now, this is a partial limbal cell deficiency following a chemical burn, which has been treated with a limbal cell transplant, and the cornea gets clear. And these are the extreme forms where you use a Boston keratoprosthesis or a odontokeratoprosthesis. Coming to the algorithm, now if you have a eye which has got only one eye, which is limbal cell is absent, you can do an autologous transplant from the normal eye or the eye which is good. On the other hand, if you have a eye which both the eyes are involved, in that case you have either you can multiply the limbal cells in your lab and grow them from a cadaver eye, and these eyes require a very long-term immunosuppression. For example, you can put them on mycophenolate or cyclosporin, and then these limbal cells survive. Now, this is one of the SLET, which was popularized by Professor Sangwan. And here the advantage is that you can have a very small amount of limbal cell, and then you can divide it into multiple 10 to 12 fragments, and you can glue them on an amniotic membrane and put a contact lens and allow the contact lens to stay for about a week or so. And you can see these epithelial cells proliferate and cover the cornea. The problem of these cells are that the orientation of these limbal cells are very important. Okay, so I just need to repeat that because you didn't see the visuals there. So this is a SLET procedure wherein you take a very small amount of the limbal cells and then you divide them into 10 to 12 small fragments, and you cover the host cornea into amniotic membrane with the stroma facing down and the epithelium facing up, and glue these small fragments with fibrin glue and apply a bandage contact lens for a week and allow these epithelial cells to grow and cover the area. The only issue here is that you have to orient these fragments in a way that the epithelium should face toward the center, not towards the periphery, so that the cells can migrate from the periphery to the center. This is the typical limbal cell transplant. You can see the OCT picture. In the first, there is a highly reflectile limbal cells, which is where there's a deficient. And once you glue these limbal cells and you repeat the OCT, you can see the OCT is much clearer and the restoration of normal epithelial anatomy is there. You can also do a conjunctival limbal autograft, wherein you take a larger portion of the limbal cells from 6 and 12 o'clock. These are the areas which are covered by the lid. So these epithelial cells, limbal cells, are not exposed by the UV radiation and they survive better. And these cells, then you can transplant them with onto the same area of the donor of the host cornea. And this is the living related conjunctival epithelial limbal cell transplant. When you don't have a normal limbal cell in both the eyes, you can take from the cadaver eyes. Of course, the survival is not as great as the autologous or a homologous transplant. Again, in this case, you need a larger part of the corneolimbal cells. Of course, the survival is less. Thank you.